Success stairs.
Success stairs.
Success stairs.
Success stairs. Success stairs.
Success stairs with Magic in Mumbai 2018.
Success stairs. It has simplified the restorative procedure for me and made my life very easy.
From the workshop, I just recognized and understood that it's actually the realest staircase to my success. Dentistry is my bread and butter, and this is what I do for living.
The thing is that it's all very practical, and what we experience in the clinic is the same thing that if you are explaining to us all practical problems. For microscope dentistry, it was down to the last detail, everything was explained and in sequence.
The whole presentation was wonderful, obviously, but the best bit was the last part, the satisfaction part. All dentists and all of us need that boost every time. And we need to tell ourselves, and somebody else needs to tell us that you should be confident in your work.
Success stairs.
Success stairs.
Hello guys, I hope that I'm online right now, so we can start the probably the third webinar this month. So it's a great pleasure for me to be here with you. Thank you, Nirai, for the invitation. Thank you all guys that you are with us. And today I would like to start with the topic of this webinar. So the topic of this webinar is tomorrow to vertical approach to the rescue. And I didn't exactly know why I chose this topic, why I called this topic like this. And yesterday I figured it out because we are in quarantine still in Poland. There is some kind of isolation. It's going better and better right now. But if you ask me why there is such unprofessional photo at this topic of this lecture, I hope you know the Paw Patrol, because this is probably one of the heroes of this situation with the COVID, because my kids are still at home from 2 months right now. So if you've got kids, probably you know this picture and you know this cartoon, and it's completely difficult situation when you've got your kids all the time in your home. So it's not very easy to not be very nervous or to lead the webinar from home. But accept this subject, the Paw Patrol to the rescue. I decided to keep this photo because if the Paw Patrol will solve all the problems. There is no any problem that they can solve. And to be honest, yesterday I just changed this photo into this, and this one maybe looks a little bit more professional, but it's completely correct topic right now. Because with the tomorrow to vertical preparation, you can solve a lot of problems. And to be honest, because of that, guys, because of the Pascal Venuti and Marco Maiolino that introduced me with the tomorrow to vertical preparation approach, and they also created the incredible Facebook group, Tomorrow to Group, that right now we've got more than 61,000 members, so it's pretty huge number. But the most important thing is that in this group I met a lot of incredible people, and I'm learning all the time from that group many things. So 2 years ago, sorry, it was 3 years ago, Pascal Venuti published the article, and he added me as one of the co-author of this article. So I didn't know about that. So I didn't know why there is so much happening about the vertical preparation, because when he introduced this article, I was like in the stage of the micro shoulder that I will prepare under my microscope. I will spend 1 hour to finish it in a very good way, and I couldn't understand why we are going back to the vertical approach. Why should it be better? Because I related the vertical approach with something really old, for the really old dentist, because my grandmother was doing the shoulderless approach, and I couldn't understand why. But just to be perfectly honest with you guys, after those 3 years when I just switch from the shoulder to shoulderless approach to the vertical approach, my dentistry completely changed. And finally I'm pretty confident about my prosthetic. I started to do a lot of the complex cases that I would like to show you today, only because I believe that this is the correct way of doing things. So I learned a lot from the group and from all the members of the group. Also because, and this is also incredible, that this is not only the group of people that share the knowledge, but we are all friends inside the group. So I met a lot of great people, like Shivangi Gavani Jain from India, who invited me 2 years ago to Mumbai, and I have to admit, guys, that India is just the country that I really fall in love. Everything is really cool. So the food is cool, the whole architecture, people, everything. Maybe the food is just a little bit too spicy for me, but it was incredible time for me, and I still have the contact with almost all that people from that photo. So this is really incredible for me. So thank you one more time, Shivangi, because maybe you are also with us here for invitation, and I hope that I will, after the situation with the virus will finish, I'm sure that I will go back to India many times. So the question for you guys for today's webinar is, and I believe that you know this question very well: can you fix it? Can you fix it, doc? Have you ever had the situation that patient came to your office and ask you whether you will repair something that is broken? And this is that strange moment, because suddenly you know how the situation looked like. So the patient is showing with the finger that something broke, and we have to make some examination, and then we have to decide whether it is possible to repair it or not. And we, or at least me, but I always want to keep the tooth as long as possible, because this is for me the best possible treatment. And if I can repair something, I really feel like the guy that is near me, the Superman, because I really feel like a super dentist if I can save the tooth. If I can't, of course we can make an implant always, but if I can save the tooth, it's really great, because I think that this is the whole idea about the dentistry, to keep the tooth as long as possible. And then the answer of us is, I will try, or maybe it's possible. But when we say I will try, then we are taking the whole responsibility for the whole treatment, even that we don't exactly know whether it's possible in the long run to save that tooth or not. And it's pretty difficult, especially at the beginning, when we see, for example, the destroyed crown, because we don't know exactly what we will find under the crown. So how we can tell to our patient how much it will cost, whether it's predictable or not, how it will behave in the long run. Because to be honest, I don't know all the answers, but there are some points that will help us with the decision and that will help us to rebuild everything from the beginning. So today I would like to show you my approach, my personal approach, how I talk with my patient, what I'm searching, what I'm looking for when I see the broken tooth, and about my RRPT protocol, because I love to create a shortcut, because this is my guide, how to make the first visit to start the whole story with the tooth one more time. So at the beginning, I always talk with my patient about the risks. So we have to make the risk assessment. And I don't know what are you taking into consideration when you want to save really damaged tooth. But those are my 5, and maybe in the future there will be more than 5. But my 5 points that I will always think about is the remaining tooth structure, so how much dentin I still have in the tooth. Then I will check definitely the X-ray and the situation with the root canal treatment or not. I will always search for the perio problems if there are some, and I will also check what will be the final work, whether it will be a single crown or it should be a bridge. And at the last point, I'll always, even that I don't like to talk about the money with my patient, but I feel that it's fair to talk about it. And probably this is the one of the things that nobody taught us. It's not so easy, but it's very important to also talk about it. So the first thing that we have to assess is this enough? Is this dentin enough to create a strong foundation for our crown or not? What we should check, and should we search for something? Is there enough of enamel? Is there enough of dentin? Is it enough foundation for the crown? So when we see that picture, we always have to think about 2 things, about the pericervical dentin and interaxial dentin. And to be honest, when we talk about the crown, pericervical dentin is the key to long-term success, because as you know for sure, we need a ferrule effect, and the more dentin, the better long-term result. And we have to check whether we can gain the ferrule or not. If not, then we have to think whether we can get extra dentin, if we can, for example, make the surgical crown lengthening to get the extra dentin to make the ferrule, because the dentin is the key, not the enamel. Enamel is a perfect substrate for the bonding, for the partial work, for adhesive dentistry. But when we talk about the really damaged tooth, we will probably not gonna talk a lot about the enamel, because when there is lack of enamel, I need a dentin, and this is the key to success. So this is why in Tomorrow Tooth Group we are talking about the 3 pillars. So we need the pericervical dentin, and we can save this dentin on 3 different ways. First of all, we will not gonna prepare the root canal from the post. So we will always take as little post as possible to put inside, but we will never eliminate the dentin from the root, from the root to put the posts. So generally speaking, we are trying to avoid posts at all if there is no need, and very often, especially in the posterior area, there is no need to put the post inside. But if we have to put, because there is a really lack of the tissue, then we will not gonna prepare the internal part of the root to put the root, to put the post, but we will find the as thin post as possible. Second thing is the shapeless endodontic. So because we don't want also to remove the pericervical dentin from the internal side, we will try to make small access to the canal. We will choose the very small taper of the file, just to keep as much pericervical dentin as possible. And the third thing is the vertical prep. So then we can save as much dentin from the pericervical dentin from the outside. So if this is possible, we should follow the 3 pillars. Then we've got the X-ray. And this topic probably is maybe not very popular, but it can be a little bit controversial. So, you know, when I check the X-rays, from my opinion and from my experience, the less previous dentistry, the better. Because when I see that somebody was using huge tapers, there is a perforation, there is a lot of dentistry inside the canals, then our chances for the long-term results are very, very small. But when I see even the very old root canal treatment with the endomethasone, with the zinc oxide sealer, with single file, I really prefer this kind of root canal treatment right now, because it's very easy to repair if something broke. So even if I see that the canal is not perfectly filled, but there are no any symptoms, or there are just little inflammation for like 10 or 15 years without any symptoms, I prefer to leave that and to make a crown. And if something happens, if there are some symptoms, it's very easy to repair. So it's easy to make the retreatment when there are some symptoms. But if there are no, I will not gonna touch this. So this is my philosophy. And the good thing about the vertical preparation, because in the posterior area we'll choose the full contour zirconia crowns very often, there is no any problem with retreatment through the crown. That I will also show you in this presentation. Another thing is the perio problems, and here we don't have a lot of possibilities. So if I see the perio problems, then very often it's very difficult to repair the perio problem. So if I see the very big tooth mobility or there is lack of bone, then we have to talk more with our patient, because then the situation is not very good, and sometimes in the long term we will lose the whole tooth. So this is the perio problems for me are pretty serious, and if I see like some big problems, I will not go with the treatment. Another thing is the type of the final work. So now, if we've got the very damaged abutment and we risk something, so it's much easier to lose just one crown than to lose a full bridge. So if I've got the tooth that there are some conditions to make the crown, and I'm not 100% sure whether it's okay or not, then I will always choose the crown, and I will not go for a bridge in the very, very damaged teeth. So, like in this situation that you can see on the slide, this patient that just destroyed all the bridges that he's got on his mouth. So even that the patient wants to make a bridge one more time, I will not gonna do the bridge in this situation, because he destroyed almost all the abutments, and if I got weak abutments, I can risk with a single crown, but I will not gonna risk with the bigger work like a bridge. And the last point is the money issue. So just because I want to be fair with my patient, and from my experience, when we are fair, when we are talking about the money in a very straight way, then it's it's even better for us. So the patient has better decisions. So I want to be as honest as possible. So I'm telling to the patient that if we have to make the retreatment, the root canal treatment right now, if we have to make a build-up and the crown, and the tooth is not very strong, maybe you have to think about the implant, because the costs are very similar right now. But we have to make to move some decision also to the patient. So if the patient tell me, I can risk with, for example, the price of the crown, and even if we fail in 1 to 3 years, it's not a big problem for me, we can start. But if the amount of money is pretty high for that patient, for a crown, or for the crown and the root canal treatment, so I will not be very prone to make a crown. So then probably I will try to push patient into the implant, because in very damaged tooth, probably this will be a better option. So just to be completely honest with the patient, that's my aim in this risk assessment. But if we've got 5 yes that everything is okay and we can move with the treatment, then we can start our first visit. So my first visit is RRPT, and you can ask why I create very often a lot of shortcuts. The first thing, that if we've got a shortcut, it's much easier to talk about it. This is the one thing. The second thing is that it's much easier to remember. And the third thing is that I really like the Star Wars, where we've got R2D2, C3PO. So maybe also this is the reason that I'm creating all the time some shortcuts. So as you can see on the right side, this is my personal robot, my microscope. So what is the RRPT? RRPT stands for remove, rebuild, prepare, and temporize. And this is how the standard visit look like in my office. So if I talked and I assess the risk, so my next visit, probably I will schedule for 2 hours. I will remove the old dentistry, I will rebuild everything, I will make the vertical preparation, and I will make the temporary crown, probably without the impression that we'll also talk about at the end of the lecture. So let's go from all the stages. So first of all, when we've got the difficult situation, we have to remove the old dentistry. And how we can explain that? So if something breaks, we have to remove it. But very often I will leave the things that work for that patient for a very long time. So in this situation, the decision is pretty easy. If we've got the fractured cusp, for example, of course we've got to remove it. If we've got the old fillings and some crack, we have to remove the fillings that are not in a good condition. And also we have to talk with our patient about the crack and about also the risk assessment. But if the root canal treatment is okay, and if there is no inflammation, and even that this root canal treatment was done like 10 years ago or 15 years ago, and it's completely asymptomatic, for me, that means that it's working for that patient, and I will not gonna remove it at this stage. If we've got any symptoms, then I will gonna remove it, and I will always inform about my patient that maybe in the future there will be a need of the retreatment, but at this moment I don't see the indication to do that. And my patient, to be honest, also doesn't have any motivation to change the root canal treatment if they don't have any symptoms. But I always afraid of the situation when they don't have the symptoms. I will make the retreatment, and then they will have a symptom. So it's possible, guys. Let's be honest. So this is the situation that I'm really afraid of. So I will never push my patient to do the retreatment if it works for a long term, like 5 years, 10 years, without any symptoms and without the inflammation. Then when we've got the crown that doesn't work for that patient, and we've got the filling that doesn't work for that patient, of course I will gonna remove it. But if the metal post still works, I will not gonna remove it. Why? Because it will be I will remove a lot of the dentin from the inside. So if I've got the metal post that work for that patient and the root canal treatment is okay, then I will gonna leave it, and later I will gonna convert the shoulder into the shoulderless approach. Of course, if I've got the bad root canal treatment with the inflammation, with some kind of with some pain, or if I've got the post that is moving, or I see the gap between the post and the dentin, like in this case, I will always replace everything. At least, however, I will right now I skip from the fiber post to the metal post. That also in the past was something completely strange for me, but right now I see much better sense in the metal post than with the fiber post, but it's completely different topic. So also, like in this situation, like in a very complex case, so if I've got the caries around the metal post, but metal posts are still stable, are not moving, and the root canal treatment underneath is okay for many, many years, I will remove what is broken, I will remove the caries, but I will leave the post, because I don't want to remove, because you know exactly how difficult sometimes it is to remove the cast post and how much dent I have to remove. So I will gonna leave it, because for a long term, the dentin is the key. The more dentin I will leave in the tooth, there is a bigger chance that everything will be better in the long run. So another point is to rebuild. So when we remove everything, so when we remove the old dentistry, then I will have to convert and fill from the shoulder to the shoulderless approach. And this is what I'm doing every single time right now. So I just finished with my shoulder preparation. So when we are talking about the rebuilding, we are going into the successor sequence stage. So this is for me the successor stage, and the all four activities that we have to do is to remove all dentistry. We have to prepare the tooth for the isolation and for the composite placement. We have to isolate if possible, and then we have to convert and fill the gap. So to be perfectly honest with you guys, these two approaches, the successors for restorative part and the vertical preparation for the prosthetic part, makes my life much, much easier. So I'm really confident right now. And for me, that was the trampoline to the complex cases, because if you are not sure about our restorative skills, it's very difficult to go into the deeper cases. If we are not very confident about our crowns, about our preparation, and we've got like on 10 crowns, we've got like 5 crowns that something is not exactly like you would like it to be, then it's very difficult to skip into the complex cases. But if everything is going in a very easy way, if you know how to deal with the deep caries, if you know how to rebuild the tooth in an easy way and prepare it in an easy way, and you don't have to remove a lot of tissue like in vertical preparation, then it's so much easier to move forward. So those are my two approaches that just make my dentistry super, super easy. So it's not, this webinar is not about the successor sequence, but I'm just taking everything that I've got from this sequence to make a perfect build up. So the successor is just the step-by-step protocol to make restorative treatment very, very easy and also affordable. So this is what we are talking during the successor courses. that we also did in Mumbai those 2 years ago. And also, if you would like to check or to learn more about the success sequence, there will be also the occasion, probably if everything will be okay with the virus this year. So probably we'll have the meeting in New Delhi, and we'll have the meeting in Bangladesh that is very close to you. So if you would like also to learn more about the restorative part, I would like to invite you for one of these 2 meetings. So when we are talking about the preparation to isolation stage, we have to think about 2 main things. So first of all, we have to remove the caries around that will be very close to the rubber dam, because we don't want to prepare nothing that will be close to the rubber dam, because we are afraid of the chopper effect or the helicopter effect that I'm guessing you know very well. And this is one of the things that that was the reason that I almost hate the rubber dam when I did it for the very first time. So first of all, without any isolation, we will have to remove everything that is broken around the cavity. And the second part, very important, is to expose the margin of the caries or the abutment, because in the way of the gingivectomy or in the way of the surgical crown lengthening. So this is a very important part, because we have to expose the margin, first of all, to put the rubber dam, because without it, it will be very difficult to place a clamp, for example, for that tooth. But the second thing right now, we are thinking about the ferrule effect. And this is amazing, that if you are able to put the rubber dam, that means that you can get the ferrule without any effect, without any problems. So to be honest, right now, my decision process is, if I can isolate the tooth, that means that I can save that tooth. So how we can expose the margin? We can do that in different ways. So if we have to remove only the gum, we can make the gingivectomy, and I'm using the Smart Gingivores set that makes the gingivectomy very, very easy. And when I have to make the surgical crown lengthening, I will use 2 options, or the burr that I will show you in a second, or the bone chisel. So how we can do gingivectomy? When we've got the bad burr, gingiva, sorry. With this burr is very easy to remove the gum in a very, very safe way. And we can remove it almost to the bone level without the risk of that we will prepare some cavity underneath the cavity margin, or we just make some bad cut or make some bad incision like with the scalpel. So to be honest, we don't need a lot of the skills to remove the gum, and we can remove it easily to the bone level. Then we can place the rubber dam, and we can make the beautiful build-up, for example, for the root canal treatment. In the aesthetic zone, when we have to think also about the aesthetic, because let's be honest, in posterior area we can cut the gum how we want without a big risk, but in the anterior area, when I want to make the gums on the appropriate level, we also have to expose, but in the more precise way. And in the anterior area, to expose the margin, I will choose the Cauter, the electrosurgery. So at this moment, when we have to think about the rebuilding of the abutment, we have to just catch the furrow. So at this moment, I will only think to try to get to the healthy tissue and to check whether I can save the tooth. If I can expose the margin and I've got 1 to 2 millimeters of healthy dentine, I can move with the prosthetic part with the rebuilding, because I know that I will gain a furrow. So if only I will catch the dentin, that's I can put the rubber down and I will have the furrow in the same time. But sometimes we will not gonna get, even if we remove the whole gum, we're not gonna get the furrow, we're not gonna get the healthy tissue, and then we have to make the surgical crown lengthening. And you know, even that before I wanted to be a surgeon, right now, because I'm more like the restorative guy, I don't like to cut the gum with the blade, because I'm not so experienced with creation of the flap. So I will gonna use simple methods like this board that you can see on the slide. That is very easy to remove the bone. So all I have to do is just to take the bore that has the active part only at the end of the bore, and I will just go as deep as, maybe not as possible, but just to get the 2 millimeters of healthy tissue. So I will remove just 2 millimeters of bone, I will place the temporary crown, and I will just wait for healing, like in this case that I would like also to present you. In the anterior area, I will not gonna use this bore, but I will use the bone chisel, the coarse bone chisel, because it's more precise. So we have to remember about invading the biologic width. So we need 2 millimeters between the gum level and the bone level. And this tool is very easy also to perform the surgical crown lengthening, because we've got this little black line. That's exactly what we need for the biologic width. So just to summarize it, in the posterior area, I will gonna use the gingivores for gingivectomy and the board that I presented you for the surgical crown lengthening. In the anterior area, I will gonna use the odontosword, so electric surgery, and the bone chisel if I need it. So this is very important, and this is one of the slides from my vertical lecture, where we divided all the steps of the preparation, like we divided the vestibular surface, interdental surface, occlusal surface. So those are the 6 points that we have to think about during the preparation of the vestibular surface of the tooth. We don't have enough time for today to talk about all that points, but I would like to focus mainly today on the height of the abutment and about the furrow, because those are 2 main points that we have to think about. So when we think about the height of the abutment, that is crucial for the good design of the crown and for the long-term success with the crown. First of all, the height of the abutment. Check this second premolar in this case. If we want to make a crown on that particular tooth, and if I have to reduce 2 millimeters on the occlusal surface, my abutment will be very, very small. And I'm not very sure whether my crown will last for a very long time when I put the crown on such a small abutment. So on this stage, I will gonna have to make the abutment longer to have the abutment in with the proper height. And in this case, I can do the gingivectomy. On the second side, the same tooth, I've got the fracture of the palatal cusp, and I've got a very deep filling. And here I will have a problem with getting the ferrule effect. So in one tooth, we've got 2 problems. First one with the height of the abutment, and the second one with getting the ferrule from the palatal side, because we need a ferrule from the palatal and vestibular, not always from the mesial and distal side, but from the palatal and the vestibular, it's very important to get a ferrule effect. So what we do in this case, we will make all the things that I talked before. So first of all, we have to remove the old dentistry that doesn't work for that patient. So I have to remove the old composite filling. I have to remove the metal pin that we can see at this slide. And even that it's very close to the pulp, I will not gonna go with the root canal treatment. Probably in the past I would, because I would afraid that I will have a problem with root canal treatment through the crown. But in this situation, I will not gonna do this, because I know that root canal treatment through the vertical crown is very, very easy and predictable. So as you can see, this is the safe preparation with MAC. So this is one of the part of the success sequence, when we can, with a very good predictability, remove everything, all the soft tissue, but leave the hard tissue inside without almost the risk of the pulp exposure. Then we can make the simple composite buildup and very easy vertical preparation around. But at this stage, we have to think about the ferrule effect from the palatal side. So if I'm checking that I don't have the 1 to 2 millimeters of the healthy dentine, then I have to make surgical crown lengthening, like I did with the burr that I showed you before. So I just drill to get the 2 millimeters to the bottom with this kind of burr. That is really, really cool. That is very easy to perform. And I've got the tissue, I've got the healthy dentin, and I've got the ferrule effect. On the second side, on the vestibular side, I want to have my abutment higher. So at this surface, the simple gingivectomy was enough to get the abutment much, much higher. Later on, of course, we'll put the temporary crown that we'll also talk in this webinar about how to produce the temporary crown. And then we just wait until the gum will gonna heal. Then we're gonna take the impression, and we can finish with the ready full monolithic zirconia crown. So another part is the isolation. And to be perfectly honest with you, I was in the rubber dam place a couple years ago, so I couldn't understand people who not put the rubber dam to all restorative treatments. So I was like the fanatic. So if there was a composite, there must be a rubber dam. But right now I'm not such a fanatic. So maybe I am for the restorative treatment, when I've got to place a filling for the class 2, when I have to make the matrix adaptation, when I need time and focus to make perfect contact point, to make the perfect matrix adaptation. But if we have to make the simple composite buildup that will take us maybe 30 seconds, I'm not so sure if I need the rubber dam in every single case. Of course, if I can, I will always place the rubber dam. But if it's not possible, or if it's problematic, I can handle without the rubber dam. So, for example, if we've got a situation like this with this central incisor, and I was really afraid that I will not gonna get the ferrule effect from the palatal side. After I placed the rubber dam, suddenly it turned out that I've got plenty of tissue there. So, like we told before, if I can isolate the tooth, that means almost now like for 95% that I can restore the tooth. So always when you can, always put the rubber dam. Then our life is much, much easier. But like, for example, with this case, look, when I remove the crown, I remove the old dentistry, I remove the cement, and as you can see, there is a beautiful little shoulder here. And this is not my crown, but I know exactly why somebody made such a huge shoulder here, because it's not so easy to make a very nice shoulder when there is the exposed furcation, because always our burr will go a little bit deeper. So I remove all dentistry, I cut the gum, and I wanted to place my rubber dam to make the filling, the composite composite buildup. But after a big fight, after I struggled for probably 15 minutes, I decided that it's impossible to place the rubber dam in a correct way. So it will not gonna help me. So I started to pack the Teflon around. But to be honest, right now I will not gonna do this. So there is no sense if we've got huge bleeding. It's much better to make just the temporary crown, to make it in a good way, prepare a good temporary crown, to cement it, and just wait 2 weeks. When we've got healthy gums, there is no inflammation, then the simple retraction cord or the Teflon tape is enough. Because to place the composite here on this huge shoulder, I need maybe 30 seconds. So what I will do, I will always convert shoulder into the shoulderless approach. And we can do it in a very easy way. So in this case, I use the Bioactiva. This is just the composite that somebody told me that it's much better than the traditional composite. I'm not so sure right now, but you can always use like the normal core build-up composite, like I'm using Clearfield right now, or any other for the composite build-up, just to place composite all around without any matrix. So we can do it very, very quickly in a predictable way. So sometimes we just don't need the rubber dam to do that. And then we can, in a very easy way, prepare the tooth with a vertical preparation with the bad board that I will show you in a couple of seconds. So look how much more tissue I get. Maybe not tissue, but why we should convert the shoulder into shoulderless. Because if I have to make exactly the same crown like before, first of all, I don't have at all the ferrule effect, because there is no ferrule, and this is a normal thing. That was the very big problem with the shoulder preparation, that when there is very little tissue and when there is a metal post, we've got no ferrule at all, because the crown will go just on the post, and the design of that abutment is really, really weak. And also, if I have to correct the margin, correct the shoulder, I will always remove more dentin. That I don't want to do this. So in such situation, I prefer to make the complete build-up, and then I can start the whole story from the very beginning. I can make a margin of my crown whenever I want. I can move it deeper. I can also stay at the same level. So I just start from the beginning, and I will not gonna remove more dentin. So even in that complicated situation, with the vertical preparation, we can still get the ferrule. And this design is much, much better than placing the crown only on the cast post. Because look how the force will gonna go. And it's so easy to bend the abutment, to bend the whole tooth structure. But when we've got the ferrule effect, and when we go a little bit deeper, the whole mechanic of restoration is much, much better. So then we've got the simple impression, simple temporary crown, the another one, and after 2 weeks we can place the ready full contour zirconia crown. But what is the very important part when we are making the composite build-up? Always prepare for a failure. So this is what we are talking before. If I got the very old root canal treatment that I don't want to touch because there is no any symptoms, but I will always prepare myself for the future root canal treatment. So I will always put something colorful on the orifice of the canals, and then it will be much easier to find it when I'm going for the crown, because you know that sometimes we'll place the crown in a little bit different angulation, and it's not so easy to exactly go inside. So for me, it's very important to put some colorful flow material on the canals, and very often I will also use different colors on different canals. So for example, if I've got some inflammation on the mesial canals and I've got the pink composite there, I will search only for the pink composite If on the palatal side, I will got the green composite, so I will just make selective retreatment. I don't want to retreat everything in the molar, for example. I will gonna treat what needs treatment, but I will not gonna go with all retreatment. So always prepare for the failure and use the color flow material. And also I prefer to use translucent composite build-up material, because then it's much easier to find the color flow material inside. If we are making very opaque composite, then it's not so easy to see the color underneath the composite. So I will always make the same approach. So first of all, I will prepare. I will isolate in the way that it's easy. So for example, in this case, there was the fracture of the palatal cusp, very popular situation, probably also with your patients. So because I couldn't place the rubber dam, because that was the fracture to the bone level, and I would have to cut the half of the palate to place the rubber dam, simple Teflon tape isolation was enough to retract the tissue and just to pour the composite everywhere. So with the shoulder preparation, that would be a problem, because it would be difficult to remove the excess of the composite. But with the vertical preparation, it's very, very easy to remove all the excess of the composite, because we will use this specific bar for this. Or like with this case. So just to be perfectly honest, this is my work, and this is the work of my mother-in-law. So, you know, this is probably the worst possible patient that you can get in your office. So after 7 years, we've got a huge failure here, and we've got the caries everywhere. And that was, to be honest, that wasn't my preparation for a shoulder, because we just made another bridge. But here I had to start the whole story from the very beginning. So what I did, I just did the RRPT. So I remove everything, then I remove everything that broke. I remove the caries one by one. So we've got here, I think, 6 abutments. One I had to extract because there was no any option to save the central incisor. But all the other, I just removed the caries, and one by one we placed the rubber dam, we placed the composite. If I see the metal post, the cast post, that works, and look how huge it is. And this is not my cast post, but I wouldn't like to remove it, because I would remove a lot of the healthy dentin from inside the root, and I don't want to do this, because probably then this incisor will not be a good abutment for the bridge, and I will convert all the shoulders into the shoulderless approach. Here we had to extract 1 incisors, but step by step, also the second side we made exactly in the same way. We keep all the metal posts inside, and we keep it for 1 month with temporary bridge just to heal. So another thing is to prepare. So we have just rebuilt the abutment. We've got a lot of the excess of the composite, and then in a very easy way we can make more to vertical preparation using the bud bore. And at the beginning, I didn't know what is the whole thing about this bore, because I know that bore was produced at the beginning for the endodontic treatment. And I remember that my dad, my grandmother was using the flame bar to vertical preparation. And when I was introduced with the bud bore, suddenly the vertical preparation was such an easy way to prepare the tooth, because we've got 1 millimeter of non-active part that will guide us around the tooth, and we just can't make any undercut. So this is like the guided preparation, and all we have to do is we just have to hold the bore in 90-degree angle and the bore will just prepare the abutment for us. In traditional BOPT approach, we have to angulate the bore in a very strange way, not to make a chamfer. So in a BOPT, we want to make also we've got the vertical preparation, but it's much more complicated, and you must be very skilled not to make the undercut, because there is the whole active part and all the bore is with the diamond. So you have to possess very skilled hand to make the very good quality preparation. With the bad bore, it's like the guided preparation, because all you have to do is you've got the not active part that will lead you around the tooth structure, and it's very easy to do something wrong with that bore. And it's very important, especially when we are making the full mouth rehabilitation, when we've got the 20 teeth to prepare, and you know how difficult and how exhausting such kind of visits can be. So this is why it's good to have any help, and this bore will help you a lot, because even if I have to, if I have to prepare like 12 teeth, I will not be as accurate at the beginning, like when I prepared the first tooth and when I prepared the 12th tooth. So if I've got the bad bore that will gonna help me, it will guide me, then quality at the beginning and at the end will be exactly the same. And this is how easy it is with the bad bore to remove the excess of the composite. So all you have to do is just to put the non-active part under the gum level and just go around the tooth. This is all we have to do. And there is no any reason that will go too deep, because it's difficult to cut the bone or to cut the gum with this non-active part. And check another one, how easy and quick can be the full crown preparation. So you can start from the side that is the easiest way. I prefer to start from the interdental spaces. Check how much pericervical dentin I will keep on the tooth. So I've got my helper, I've got my bore, and it's very, very easy to prepare everything, because everything, the non-active part is guiding me all the time. All I have to do is to hold my bore in the right direction, in the right angle, to stay as much in a vertical as possible, to have the parallel wall of the abutment. So, today I need like 5 to 10 minutes to prepare the tooth for a crown. But in the past, when I was doing the micro shoulder under the microscope, I needed like 1 hour to make the perfect margin under the microscope. I was smoothing everything. I was using the enamel chisel to make the perfect 0.1, 0.2, 0.3 shoulder. And to be honest, I didn't get better result. With vertical preparation, I can get also the brilliant fit of my crown with much easier and quicker way. So the last point is to temporize, and this is a very important thing. So there are many things that we should talk about the temporary crown when we talk about the vertical preparation. But the main 3 points is that we should use the thicker material than bisacrylic. So for the it's much better to use meta-acrylic. So the powder and the fluid. I'm using the Jet Kit acrylic. That is very, very good for temporary crown. The second thing, however, there are many different opinions about that. We should make the shorter temporary crown because then the healing of the gum is much, much better. And we will always remove all the temporary cement. And the last thing is to finish the temporary crowns much better. And you know, to be honest, in the past, I wasn't focusing a lot about the temporary crown. So, you know, I thought that, okay, let's make some rubbish temporary crown and it will be okay, but it will not be okay. So right now, I'm much more precise about production of temporary crowns, because if you make beautiful temporary crown, you will get perfect healing and you will have the beautiful tissue for impression and for the cementation. And this is what also guys from the Tomorrow Tooth, mainly Bogdan and Katrina, taught me how to prepare beautiful temporary crown. So bisacrylic is not the best material for the temporary crown when we talk about the vertical preparation, because the margin will be too thin. As you can see, this is the same temporary crown made of the metacrylate on the left side and from the bisacrylic on the right side. And as you can see, it's in the cervical area, it will be very, very thin with bisacrylic, and it's very difficult to make it smooth. So metacrylate is much, much better. We've got many options, to be honest. We've got the metacrylic. We've got also, I would like to show you, first of all, the film, how we will prepare the temporary crown. So when we will have the resin, then it's very good to take a pencil and to mark the border of the crown, and then using the carbide burrs, because this is the best option for the metacrylate to make our crown sharp. And it must be very sharp and it must be very, very smooth. So then you can use all the polishing materials, the rubber cast, you can use the powder for polishing, everything that makes your crown will look very shiny and will be as smooth as possible. However, the best possible option is to use the PMMA shell. So we can order from our technician the milled shell from the PMMA, and we can reline it with the metacrylate. And this is the most, this is the best way, but in the same time, it's the most expensive way. However, to be honest, at the beginning, I wouldn't even think about this method because it was too expensive. Right now, I try to make dentistry slower and more predictable. So right now, I'm going back to PMMA shell. I like to work for a longer period of time on the temporary crowns, and then I see that my final work will be much, much better. So the last question that I would like to answer during today's webinar is, can I take an impression on the same visit as the preparation? Because to be honest, that was my first question when I was during my first vertical course to Pascal Venuti, because I wanted to make everything as quick as possible. I want to make the preparation, I want to make the impression and have the ready final crown for the next visit. Yes, you can take the impression at the same visit, but let's think whether it's the perfect option for you. Sometimes it's much better just to wait 2 weeks. And this is what we recommend, especially at the beginning, when we have to learn a little bit more about vertical preparation. Because one of the things is, for example, like in this case, when we've got the fracture almost to the bone level, I made the composite buildup and I made the preparation, and you can see how much blood there is, how much everything there is. So because I don't want to invade the biologic width of my crown, I will make the shorter temporary crown. I will let the gum to heal 2 weeks, and you can see how beautiful tissue you can get when you produce the nice temporary crown. And on this tissue, it's so easy to take the impression. So I know that in this situation, when I've got already healed gum, I will not gonna invade with my crown biologic width, because right now I've got the gum attached to the level when the organism want to have the biologic width. So it's much easier and it's much more safe for you to produce the crown in this way. And we can make beautiful, the final full contour zirconia monolithic crown. We can cement it and it's much more predictable. And also, as the last case that I would like to show you, if we work for a longer period of time on the temporary crowns, we are more safe. Because look, another case with the fractured, this time I think it was the buccal cusp. So we did all the RPT procedure. So we made the, we removed what we had to remove. So the fracture cusp, we made the composite buildup, we made the vertical preparation, and we made the temporary crown without taking an impression. And after 2 weeks, when patient came for the impression, I removed the crown and look what I found. So there was the tissue on the mesial side and the buccal and the lingual side was really nice, but on the distal side there was an inflammation, and I didn't know why. And then when I checked it in a more precise way, I recognized that there is the ledge of the composite that I didn't see at the first visit, because when we were making the vertical preparation, there is always a lot of blood, and sometimes you can miss something, you can make a mistake. So I correct the composite on the distal side at this visit, and I didn't take the impression. I just relined the temporary crown, and after 2 weeks I got this kind of tissue, and right now I know that I'm safe. So if I took the impression at the first visit, I would get the final crown with the ledge of the composite. But because I postponed the impression till the next visit, I could repair my mistake. And this is much better, more predictable, and less stressful dentistry for me. So right now I just will gonna wait until I will have the perfect tissue on the temporary crown, and then I'm sure that I will have perfect tissue also on the final crown, like in this case. So then I just took the simple 2-stage impression. I sent the color of the abutment to my technician, and I got beautiful full contour monolithic zirconia crown that has perfect finishing. So this is a very important part. This is why we have to also to focus on production beautiful temporary crown, because then we know what to expect from our technician, how the final crown should look like. So we need very, very sharp edges of the crown with just the smooth zirconia. There shouldn't be any ceramic on the border of the crown, and we can cement it without any problem. So if there is inflammation, even the cementation is problematic. If you've got perfect tissue, then the cementation is just a piece of cake. We just take the glass ionomer material, we just plonk, and we've got the crown on its place. And it's also very important to take the photo, because as you can see in the photo on the X-ray, there is some cement left that needs to be removed. So just as the final thing, if I would like to give you some to home tip: be careful with the shortcuts. So it's much better to make the slow, simple dentistry, and don't take the shortcuts, because sometimes shortcuts will finish with the huge mistakes. I did a lot of mistakes, and to be honest, it's nothing wrong. It's making mistakes, but we always have to learn. So right now, because I even like to make some mistakes, because then I can learn something new. But if you see that something doesn't work, always be a detective. Always search what can be the wrong thing. And if I make a mistake, I will always make it better next time. I will try to repair it, cost-free for the patient. But then not only I will have beautiful case for Facebook, but also I will feel that I just learned something new. So making everything in that situation, we just change the idea of mistake, that it's not something bad, but this is just the chance to be better dentist. And with this approach, the dentistry is still big fun for me, and I'm sure that it's also for you. And as I know, some of you doesn't work for like 3 months now, so it's not a very cool options. So probably you also want to go back to the office just to make some good filling, make some crown, and the vertical approach for the crown is the thing that will make your dentistry and prosthetic much, much better. So as I've got some information, because we just finished the lecture, if you've got any question, you can ask them on Facebook, and we will, so I will just so we will have this question here, and if you want me to answer something, just write, and we've got the half hour for some question. If you've got some question later, you can contact me through the Facebook, and I hope that when the situation will be better with the virus, we can visit in person, or in Delhi, or in Bangladesh. So you are invited to one of those two events. So I will just check if we've got any questions or not. Yeah, there is. Okay. I will just read something, and I will check if we've got some. Hello, Hubert Chu. I see Swapnil. A lot of friends here also. So cool that you are here. Guys, Jatin. Hello, Jatin. Okay. Okay, we've got the question. Is this vertical preparation concept similar to stainless steel crown preparation in pediatric dentistry? Yes, it's similar. We can also make the metal crowns for vertical preparation. Definitely, in the past we didn't use the bud bore, so this specific bore that we talked about, but we also can make the metal crown. However, because with the metal crown you always have to make the metal color, so you always have to like the piece of the metal on the edge of the crown, because it must be very, very sharp, and we can't cover the whole metal with the porcelain. So I just switched to the full contour zirconia, because it will be much easier from the aesthetic point of view. And if I have to make the retreatment, the root canal retreatment, it's also much easier to make it with the full contour zirconia crown. But it's also predictable, and you can also use the metal crown as well. Okay, what composite should be to build up? Flowable, packable, or dual cure? Right now I'm using the dual cure material. I'm using the clear fill from Quarry, and it's pretty easy material, and it's really good for for the post, but there is not such a big difference. You can use also the flowable in some situation. You can use the normal packable, but I'm using the dual cure because it's much easier. So I can do it much faster with the dual cure, just to put from the syringe everywhere the material, and I can light cure, and then I will wait a couple of minutes. So dual cure is my choice. What do you prefer to use and to have safety restoration, fiber post or steel one? Definitely the steel one. So right now I'm not using the fiber post at all because it's too flexible and I don't want to have any flexible material inside my canal. However, I know why do you ask, because I've got, I was using the fiber post, like hundreds of fiber posts in the past, but from my experience, and probably not only mine, in the situation when we really need a post, fiber post will not gonna work. So I've got a lot of the failures with the fiber post, and the worst one is the cementation. This is probably the most the popular one, and in the same time the worst one, because with the cementation very often this is the road to bacteria inside the canal, and when patients come to us, to our office with the post inside the canal, there is nothing to save. So definitely I will choose the metal post, but I will not gonna remove the dentin to put the post inside. So I will take as small metal post as possible, and I will make the passive fit. So I will never screw it inside, but I will just put inside and cement it. That's all. So we need the metal post just to make our construction more stable and much harder. Please share burn number to use in the verti. Guys, I've got this slide, but I would have to find it. I can't do it right now because I don't want to click anywhere, because I'm afraid that I will make some mistake and we will not have the connection. But if you want the burn number, you can go to my Facebook page, the second one that you can see on the screen, like Dent.MACIEJ CZERWINSKI, and then you will, when you go to the photos, you will find the case with the exact burn numbers. So if you've got any question, just also you can write me personal message, I will give you the link, or you can go to the link and you will find everything, because there are many different distributors, there are many kinds of bad birds, and you have to be careful because some of them are not the proper one. So you have to be careful with that. Okay. Do you bond? There is a question. Do you bond the monolithic zirconia crown, or do you use the glasionomer cement? Definitely, I will use the glasionomer cement. Why? Because it's much easier to remove the excess. And I had many failures also because of the debris of the excess of the composite cement, and you know how difficult it can be to remove in the past. So definitely glasionomer. But if I see that my temporary crown is falling, then I can always have the option for the adhesive cementation. So if I've got, for example, very small abutment, then I've got the enamel, then we can use also the composite cement and make the full protocol of the adhesive cementation. But if I've got the proper design, proper abutment, good ferrule, good design, so parallel walls, I will choose definitely the glasionomer. Sorry, guys. What do you use to cover the root canal orifice with in case a root canal treatment is required? Thank you. Okay, so I'm using the color flow material, like I said in the presentation. So I will choose, if I've got 3 canals, I will choose three different colors, just to prepare myself. If I see any inflammation in the future, I will just search for the exact color and I will make the retreatment of some specific canal. So with the color flow material, it's much easier to locate the canal through the crown. Okay. Okay, I can see the message that from the Brufi that he's doing the vertical since 2 years after the course in Mumbai, and very happy to hear that. Some tricks. Oh, can you give some tricks about the technical part of final crown, like friction and others? The question from Ili Lavita. The topic of the friction and how to design the crown is pretty long, and I wouldn't like to give you just some short information, but there is a very good article about that on the web page CZERWINSKI. Also, you can write to me and I will send you the link to the article. So on the Tomorrow 2 group also you will find, if you search for the die spacing and the friction, you should find the article of Pascal Venuti and Massimo Mazza, I think, about the friction and how to design the crown and how to make the perfect friction. So this is the best source probably. Any specific tips for cementation protocol? So, I try to make as easy protocol as possible, because you know how stressful it can be if we have to place the lower 7 crown when there is a lot of saliva, tongue, cheeks, and so on. So this is why I will use in 90% of cases, I will use the glasionomer cement, when first we have to clean the abutment, and there are many ways to do that. You can sandblast, you can clean the abutment using the rubber wheels or anything that you want, but we have to make the abutment clean and just then the plumb. But the main thing is to get the very good quality temporary crown. If you make the temporary crown in a good way, you will have the healthy tissue, and then the cementation is very easy. But sometimes we will also, if I need better connection, then we can make the traditional adhesive protocol, for example, like for the adhesive bonding of the Emax crown. So it's up to you. Fit check. What is your choice of material for a vertical prep tooth in clinical situations which are not advisable for monolithic zirconia? So in 90% in posterior area, I will use the monolithic zirconia, but in the front area, because of the aesthetic, I will use the Emax crowns. However, at the beginning, I was afraid of that because I was afraid of cracks and chipping. But to be honest, I made like hundreds of the Emax crowns right now, and I got only one fracture till that moment. So it's really predictable for me right now. However, many technicians at the beginning didn't want to make the vertical Emax crown, so you have definitely to talk with your technician, because there are some points also about the friction and about the inverted die spacing that your technician have to acquire to the whole technology. So it's very important to guide the laboratory steps, and I would advise to all of you to go to Italy, to the Emanuele Tarassio. That is incredible technician. and I'm also going, when the coronavirus will not be in Italy, I will go to Emmanuel just to see all the lab stages of the vertical approach, because the technician is the 50% of the success. So they must know exactly how to finish the crown and how to design it well in the MyLink machine. Okay, guys, I think we've got all the questions answered. So thank you one more time. It was a great pleasure for me to be with you. And maybe we'll make another webinar in some time. So I really would like to thank you one more time, say that you live in a beautiful country, and I wish you all the best, and hope to see you soon, also in India, this time in New Delhi. So see you guys, and that was a pleasure, and good luck.